latest advances in advancements in gynecologic cancers. I realize that there's a lot of information in this slide deck, and I might go over some of it kind of quickly. So at the end, if you don't mind waiting till the end, if there's anything that wasn't clear or you want me to elaborate on it, just bring it up at the end of the presentation. And, I thought I would start out by talking to you about what a gynecologic oncologist is. Now, gynecologic oncology is the specialty, and I am a gynecologic oncologist. So some people will call me an OB/GYN cancer doctor or a OB/GYN oncologist or or a gynecologist. So there's a lot of kind of misunderstandings about what a gynecologic oncologist is. And so as a MD, I go to 4 years of medical school. And then during medical school, I decided to go into OB/GYN residency. So I did 4 years of OB/GYN residency. And then anybody that finishes an OB/GYN residency can decide they just want to do general obstetrics and gynecology, like deliver babies, do pap smears, do birth control, do all sorts of things like that. Or they can decide that they want to do a fellowship, which means subspecialty training. And so there's 5 or maybe even 6 now certified fellowships in OB/GYN. And one of them is gynecologic oncology, which is depending on where you go, it can be a 3 to 4 year fellowship. So I did 4 years of medical school, 4 years OB/GYN residency, and then I did 4 years of GYN oncology fellowship at University of California, Irvine. So it's a real long haul in terms of education. And you can't be a gynecologic oncologist if you do a different residency, meaning you can't do internal medicine or general surgery and then do GYN oncology fellowship. You have to kind of start with the OB/GYN residency. So it's a little confusing and definitely a very unique specialty. So we take care of women's cancers below the waist is what I say. So these are cancers that originate or they start below the waist and are specific to a female, like the female gynecologic system. So uterine cancers, ovary cancers, fallopian tube cancers, cervical cancers, vaginal cancers, labial or vulvar cancers. We deal with cancers of all of these organs, and those organs specifically. You might run into a gynecologic oncologist that has had breast cancer training, but at this point, it's very, very rare to run into that. And so gynecologic oncology as a specialty, we take care of those cancers like I said we did. And then we also might take care of precancerous conditions, like you can have pre-invasive conditions of the vulva, the vagina, or the cervix. You can even, I left it out there, but you can even have a precancerous lesion of the endometrium or the uterus. And so sometimes we will see patients that don't have a cancer diagnosis, but they have one of these pre-invasive diseases. Now, the other unique thing about gynecologic oncology compared to medical oncology or a breast cancer surgeon or a colon cancer surgeon is that we are trained to do chemotherapy and surgery. So pretty much we're the only cancer doctors that are trained to do both. So about half of my practice is managing chemotherapy and half of my practice is doing surgery. And so some gynecologic cancer doctors out there in the world or in the US or in California decide that they don't want to give any chemotherapy, and that's their decision. And they might work with a medical oncologist who gives chemo, and they might only do surgery. And that's their decision, but they have to be trained in chemotherapy. Like when we go to get our license or our board certification in GYN oncology, we have to learn and show that we have learned about chemotherapy. So it's a very unique field. It's kind of like if you were a breast cancer patient and your surgeon also did your chemotherapy, like you didn't have to see 2 different doctors. or if you were a colon cancer patient and your surgeon that removed your colon also did your chemotherapy. So it's GYN oncology is a very unique specialty. So we can't cover everything today, but we're gonna, and I guess I should make sure, okay, make sure about the time. So, but these are the things I kind of want to highlight. So, because they're sort of the latest and greatest. So we just got the American Cancer Society statistics from that are predicted for 2024. And so I'm going to review those because those are kind of hot off the press and have some interesting and very important highlights. And then we'll start off with ovarian cancer, discussing some of the latest advances in diagnosis and treatment. I'm also going to hit on some controversies and some areas that are very difficult for patients and family members to really understand. And then we'll talk about uterine cancer, again, some latest and greatest in terms of advances in diagnosis and treatment. And we'll finish with cervical cancer. And unfortunately, we just don't have time to really go into cancer screening in details or therapeutics in details, or even the vulvar or vaginal cancer details, or this other kind of rare cancer called gestational trophoblastic neoplasm or disease. So I apologize if you're listening in with hope to review those two cancers, because we just don't have time to do that today. But I want to highlight that all of the gynecologic cancers have their own ribbons. And one time I did a focus group with gynecologic cancer patients, and one of the kind of highlights of that focus group was that these patients were sick of seeing everything, all these ribbons for breast cancer, and they really felt like they were under-recognized or even not recognized at all. And, you know, you go to buy a Yoplait yogurt and you see a breast cancer ribbon, or you go to an athletic game and you see everybody's cheering for breast cancer research. So sometimes gynecologic cancer patients really feel left out in terms of being recognized and spent and paid attention to. So I can definitely appreciate that. But gynecologic cancers all have their own ribbon, and we should continue to advocate for more time spent on education and research. So like I said, this first part of the talk, we're just going to be talking about numbers and where we are in terms of statistics for gynecologic cancers. And these slides all come from the American Cancer Society. If you don't know about that website, it's cancer.org, O-R-G, cancer.org. And you don't have to have a subscription. You don't have to pay money. You don't have to even register online with your email or anything. Anybody can get access to these statistics. And you can even see what things look like in California specifically. And it's kind of fun to play with those slides and that information that they give. So these are the estimated numbers of new cases in the United States only in 2024. So there's an estimate that in women, there will be 67,880 new cases of uterine cancer. So that includes endometrial cancer, that's uterine cancer. So notice that a couple things. You don't see any of the other gynecologic cancers come up in the most common cancers in women. So that's something to note. But then also notice that colon cancer and uterine cancer are getting pretty close together. And some of us think that uterine cancer is going to come up to the number third in the list in the future. So we think that uterine cancers are increasing and that they're going to maybe even become more common than colon cancer in the future. And, you know, maybe we're going to see that also lung cancers kind of decrease with time. Who knows? We'll see. But uterine cancer is becoming more and more common. Now, this is another slide that estimates the number of new cancer deaths in the United States in 2024. It used to be really that ovary was the only gynecologic cancer that was in this list, but now notice uterine cancer is in the top 10 most common cancer deaths in women in the United States in 2024. So about 1,000, well, a little less than 1,000 more estimated cases of deaths from uterine cancer versus ovary cancer. So definitely two of the cancers that I treat and that gynecologic cancer doctors treat are in the top 10 most deadly in women. And so Many of us emphasize that because that's bad news. We need to work on this. We need to really help to have walks and advocate days dedicated to walking for ovary and uterine cancer, just like people walk for leukemia or lymphomas and stuff like that. So really, for example, we have a walk here in September for ovarian cancer research. And there were good enough number of people that showed up, but not nearly the same number of people that show up for some of these other walks, like leukemia walks and breast cancer walks and stuff like that. So we really need to get people out there and advocate for funding and attention. And then here's a trend in 5-year survival rates. So some good news. You'll see that since 1975, to 2019, ovarian cancer 5-year survival rates have improved. When I was in training, I used to tell a patient the 5-year survival rate for an ovarian cancer patient was 40%, but you can see it's now about 10% higher. It's about 50% or a little over 50%. And I'm going to show you some slides later on where for some patients that have ovarian cancer, it's even higher than that, like maybe 60, 70%. So definitely we're making some improvements. Unfortunately, though, the 5-year survival rates for cervix and uterine cancer have both decreased. So cervical cancer, which is a completely, well, I shouldn't say completely, an almost completely preventable disease, the survival rates have decreased. So that's pretty concerning. And then in uterine cancer, which actually has a symptom that we if we pay attention to that symptom, sometimes, most of the time, we can find the cancer early, but not always, but a lot of the time. So unfortunately, in uterine cancer, the survival rates are also decreasing, which makes me think we really got to educate women about the symptoms of uterine cancer. And for cervical cancer, we really got to educate women about ways to prevent cervical cancer. And then definitely in certain races, survival rates are lower than in other races. Like, for example, in uterine cancer and cervical cancer, the 5-year survival rate for Black women is, 10 to 20% worse than for white women. And so this is also an area that we're really trying to pay a lot of attention to in terms of decreasing this disparity. And you'll see this other slide is the trend in deaths from uterine cancer really rising in Black women. And the slope of the rise in death rates is there in white women, Hispanic women, Asian, and Alaskan Native, American Indian, Alaskan Native, or Asian women. But the slope of the rise in death rates is not nearly as high as those in Black women. But I will say for all women, uterine cancer is one of the cancers that is on the rise compared to all the other cancers that we see in the United States. So that is the end of sort of our number discussion. So some interesting highlights and some things really that we need to focus on. But now let's dive right in to ovarian cancer. And so if you remember, ovarian cancer doesn't make it to the top 10 most common, but it definitely makes it into the top 10 most deadly in the United States for 2024. So we need to continue to educate and advocate about it. So this is the ovary on the left. Now the ovary has multiple components to it. And the area where, and I think, let's see, yeah, I have a laser pointer here that I'm going to use to show you. So the area where most of the ovarian cancers start is in the epithelium here. So these like square-like cells on the epithelium of the ovary is where most ovarian cancers start. But you can also have ovarian cancers that start in the stroma of the ovary or in the germ cells of the ovary. Now, the cancers that start in those two locations, like for example, a granulosa cell tumor or a dysgerminoma of the ovary, those are not as common, and those start in a different location than the epithelial cancers. Now, I want to make the point that when I talk about ovarian cancer, I'm also including in that definition something called primary peritoneal cancer. So primary peritoneal cancer is a cancer that starts in the lining of the abdomen called the peritoneum. And it happens to be treated the same way and act the same way as an ovarian cancer. And so even though it didn't start in the ovary, we treat it and we call it and we approach it the same way as we approach ovarian cancer. So when I use this word ovarian cancer, I'm including cancers of the peritoneum called primary peritoneal cancer. And it's because these little square-like cells are the same cells that line the peritoneum. And so really we treat them in the same way. And epithelial ovarian cancers, not these other types, but epithelial ovarian cancers are related to ovulation and increase in ovulation over time. So, for example, the more time in your life you spend on birth control pills, which reduce ovulation, being pregnant, which reduces ovulation, lactating, which reduces ovulation, meaning breastfeeding, the more time you spend in those states of lack of ovulation, we think your chance of epithelial ovarian cancers decreases. And that also goes for women that have a later time that they started their period or an earlier menopause. Again, anything that kind of reduces ovulation in your life is thought to also reduce your risk of epithelial ovarian cancers. And so this is a hot topic and we don't have a ton of time to spend on this, but there is a blood test called a CA-125, and a CA-125 is a blood test that's called a tumor marker. And that tumor marker helps us, once we know you have ovarian cancer, helps us to monitor you. Now, it's not a perfect test. So you might have an ovarian cancer recurrence or an ovarian cancer diagnosis that is not associated with an elevation in your CA-125. But more commonly, you do have an elevation in your CA-125. Now, the problem with this blood test is it's also elevated in conditions that are not cancer and can be elevated pretty frequently in these conditions. Like, for example, infection, fibroids, pelvic inflammatory disease, alcoholism, pregnancy, menstrual cycles. So a lot of benign, like a lot of normal states and a lot of disease states that aren't cancerous can cause elevation in your CA-125. For example, I had a patient once that had rheumatoid arthritis and ovarian cancer. Her CA-125 never got to normal range. And she had to just accept this as a reality that she was never going to have a normal CA-125 because of her rheumatoid arthritis. So the reason I really highlight this is that CA-125 cannot be used as a screening test. So we don't have a screening test for ovarian cancer. So people will go to their primary care doctor all the time, or when they see me, they'll say, why wasn't I screened for this? Like, why didn't I get a mammogram for ovarian cancer? We don't have a screening test for ovarian cancer. In fact, the only gynecologic cancer that we have a screening test for is cervical cancer, and that's the only one. So we need to spend time maybe researching this. Ever since I've been in training or in medical school, people have been trying, but we just haven't found a screening test that works and is accurate enough. So what do we rely on? We rely on symptoms. And I used to practice gynecologic oncology in Arizona, and there was a advocacy group, like a nonprofit group that spent a lot of time focusing on ovarian cancer symptom education. Like they used to stand in parks and hand out little business cards about ovarian cancer symptoms. So what are the symptoms that we can educate on? Feeling full quickly, abdominal bloating, urinary frequency, pelvic pain. We can educate about those. And guess what? If you're a woman, you have those symptoms at least once in your life, if not multiple times in your life. And guess what? You don't usually have cancer. So we have to emphasize that these are symptoms that go on for a long time without improving. So if you have 2 to 4 weeks of these symptoms and they're not improving, and in fact, they might be worsening, definitely we want to educate women, they got to go in and get checked. So that's really what we rely on to try to find the cancer early, because we don't have a way to find it early. We do, however, have a way to find women that are especially high risk to develop ovarian cancer. So ovarian cancer happens 1 in 70 women. But if you have a BRCA mutation, so if you have a hereditary breast and ovarian cancer mutation, you have about anywhere from a 10 to 40% chance of getting ovarian cancer by age 70. And so we know now that if we test women that have ovarian cancer for a BRCA mutation, about 20 to 25% of them have this BRCA mutation. And of those that have the BRCA mutation, about 10 to 20% actually inherited it from their family members. And so if we know that that woman has a BRCA mutation that they inherited from their family members, we can then test that woman's family members to see if they have this mutation, and then prevent ovarian cancer in those family members. And so this is another area that we really need to educate on. And if we know those women have that hereditary risk, we can talk to them at about age 35, anywhere from 35 to 45, about removing their ovaries and tubes prophylactically. That means taking out, this is what the ovary looks like, a normal ovary. This is what a normal fallopian tube looks like. We recommend in those women that are high risk for developing ovarian cancer, removing these structures before the cancer develops. And you have to remove it between age 35 to 45 in order to get it before a cancer actually develops. And so that's a very special conversation to have with those women, and potentially life-saving. So now I want to kind of jump, I'm going to take a sip of my tea here. I want to jump into treatment options. So we're still working on this. There's still research to be done, but we've done research on whether or not you need to have surgery first when you're diagnosed. So some women, for many reasons, can have surgery first before they have chemotherapy, meaning they come to see me, they have a pelvic mass, they might have a mass somewhere else or fluid in their abdomen, and I have to make a decision as to whether or not I can do surgery on that patient first, or would she better be served by doing chemo first. So what I encourage patients to have an open mind about is having surgery first doesn't necessarily mean that you're going to live longer or do better. In fact, one of my patients that's lived the longest of any of my patients with stage 4 ovarian cancer had chemo first. She did not have surgery first. So there's an option when you're, not an option, but there's a difference in how you're treated when you have a diagnosis of stage 3 or 4 ovarian cancer. Some women are able to have surgery first, and other women are able to have chemo first. And it's a very kind of specific decision that the doctor, the gynecologic cancer doctor, has to make. And so either way, each patient group gets about 6 cycles of chemotherapy, either before and after surgery or only after surgery. And we're still working on figuring out how to put patients in these 2 categories. We have some knowledge about who's going to do best with this category versus who's going to do best with this category, but we're still working on it. And so surgery for an early cancer, and we only find ovarian cancer early in about 10% of patients with ovarian cancer. So it's not very common to find it early. But in that situation, you may have laparoscopic surgery to diagnose it, or robotic surgery. And we're just removing the ovarian mass, maybe the uterus, and doing biopsies of things. But if you present in as an advanced stage, like stage 3 or 4, you have what's called a debulking surgery. That means we go in there, we don't just remove the ovarian tumor, but we remove little pieces or big pieces of cancer that are all over the abdomen sometimes. And possibly that includes doing a bowel resection. Chemotherapy includes usually what we call carbotaxol. That's like the gold standard for ovarian cancer. Chemo is carbotaxol, which is carboplatin paclitaxel, but we just abbreviate it as carbotaxol. And many patients these days get a 3rd or 4th drug even for their initial chemotherapy. Some patients get this drug called bevacizumab, which is added to the carbotaxol. It's otherwise known as Avastin or Zirabev. So there's different brand names for it. And then many patients at this point get maintenance therapy, and maintenance therapy can include bevacizumab or a PARP inhibitor or a combination of bevacizumab and a PARP inhibitor. Now, I encourage patients to ask. If they're only getting carbotaxol, advocate for yourselves by asking about these other two agents and if you're a candidate. It doesn't hurt to bring it up. I mean, your doctor might say, you know, you're not a candidate. Or, you know, they might give you an explanation as to why they do or don't use that. So, but I think if they don't bring up any of that, no bevacizumab, no PARP inhibitor maintenance, ask if you're a candidate. It doesn't hurt to ask. And then what's new for ovarian cancer in 20? We're getting we're losing time here, so let me try to speed up here. So what's new with ovarian cancer in 2024? Again, this idea that maybe neoadjuvant chemotherapy is good for a lot of patients, especially patients where we don't think we can remove all of the cancer at initial surgery. PARP inhibitors, like I said, these are pills that you take in maintenance, and many patients, at least 50% of patients with ovarian cancer, are eligible for one of these PARP inhibitors in maintenance. So again, if you're not offered it, tell your family member or your friend or yourself to ask about it. In general, patients are living longer than we've seen before. And so we're really pushing the survival curves. We're not using intraperitoneal chemotherapy like we used before, but now we're starting to look into something called heated intraperitoneal chemotherapy. And so that's starting to become something we're more interested in. Immunotherapies are disappointing for ovarian cancer patients, but there's more studies that are going to result, and maybe we'll be able to find a better immunotherapy drug. And then there's new therapies for recurrent disease, which is also called targeted therapy, which is exciting. So now we see that 50%, not 40%, but 50% are still in remission at 5 years. That's great, meaning they haven't even had a recurrence. In some patients, 60 to 70% are still in their second remission at 5 years, meaning they might have gotten one chemotherapy, but they're still in remission at that 5-year mark. And in some patients, especially those with the BRCA mutation, 70% are still alive at 7 years. So all of these patients started with stage 3 or 4 disease. So imagine having a stage 4 cancer and your doctor telling you you have a 70% chance of being alive at 7 years. So that's really a breakthrough for our ovarian cancer patients. And we're still working on trying to make this better. So let's jump right into uterine cancers or endometrial cancers. Take another sip here. So these are the endometrial cancer risk factors. Now, you know, I want to point out a couple things here. Estrogen is definitely a risk factor. So if you've been given estrogen and you have a uterus and you don't have progesterone, either taking it by mouth or a cream or whatever, if you don't have progesterone around to counteract that estrogen, you could develop endometrial cancer. Older age is definitely a risk factor for endometrial cancer. Obesity is definitely a risk factor. Now, I want to point out, because a lot of women get confused about this. Not all obese women are at risk for endometrial cancer. And just because I had a patient tell me this the other day, that she's obese and her doctor told her to get her uterus out because she's obese. Now, that is not what we usually say. We don't say because you're obese, you need to have your uterus out to prevent uterine cancer. So it is an associated risk factor, but not all obese women get endometrial cancer. And we need to work on trying to figure out who exactly in that obese category is highest risk for uterine cancer development. It is a risk factor, but it's not the end all be all. Nulliparity, which means not having had children, early menses, meaning starting your periods early, unopposed estrogen when you're taking hormone replacement therapy, and some other genetic syndromes, tamoxifen, a granulosa cell tumor. So these are risk factors we know about. These are potentially associated risk factors, and these are actually protective risk factors. Like I said, more progesterone actually protects you, like a progesterone IUD, for example. Taking birth controls protects you. And actually smoking for some reason protects you. Of course, we don't advocate patients smoke to do this, but we do notice in smokers, they are more protected, not perfectly, but more protected against endometrial cancer. So what are the symptoms of endometrial cancer? Atypical bleeding. So many of us have regular periods when we're premenopause, right? And when you're postmenopause, you're not supposed to have periods anymore. Even if you're on hormone replacement, you're not supposed to have periods anymore. And so that's commonly misunderstood. So I saw two patients, one close to 70 yesterday and one 78, that both told me that they never stopped having periods. Now, that is not normal. If you don't ever stop having periods by age 55, you should definitely be seen by a doctor. And most women actually do come and get seen. If you are premenopause and you're having irregular bleeding, you need to come in and be seen. And for women that are postmenopause that have irregular bleeding, it's cancer till proven otherwise, meaning we have to do something to rule out a cancer. The most common cause of postmenopausal bleeding is not cancer, but it's cancer till proven otherwise. And so sometimes we'll do an endometrial biopsy. Sometimes we'll just go to the surgery center to do something called a DNC. We usually will also do an ultrasound, and sometimes we'll do something called a hysteroscopy, which can be done at the time of DNC to visualize the endometrium. And this is how we do a biopsy. We put an instrument inside the uterus to grab some cells in the endometrium. Now, these days, we know that endometrial cancers fit into 4 major subtypes. And so if you have endometrial cancer, or if you have a family member that has endometrial cancer, the doctor, the medical oncologist, or the gynecologic oncologist, might bring up one of these 4 categories. And if they don't, just like I told you to advocate for maintenance therapy in ovarian cancer, if they don't tell you one of these categories on your clinic note or when you're talking to them, ask if you fit into one of these categories, because that will help the doctor to remember this, or to have them put it in the note, or even maybe to have them remember this and think, oh, she's P53 mutated, or she's deficient in MMR, maybe I should consider a different treatment. So if you don't see this in your note, or they haven't talked to you about it, ask. It doesn't hurt to ask. And I get it, some doctors maybe are offended when patients ask this information, but you got to advocate for yourself. Because for me, even sometimes I forget to mention something to a patient. I'm not perfect. Sometimes I don't put it in the note like I should. And I appreciate it when a patient brings that up to me. Like, I didn't see you put that in my note, or you didn't tell me if I have this risk factor. It's definitely helpful for sure. So thankfully, most uterine cancers are diagnosed in early stage. And if they're diagnosed in early stage, the 5-year survival rate is very, very good. But you can see this 5-year survival rate go down and down and down as you get closer to a stage 4. Remember, I said some ovarian cancer patients with stage 4 have a 5-year survival rate over 50%. But in uterine cancer, the 5-year survival rate for stage 4 is 15 to 17%. So very, very bad. Historically, we're getting better if you have a stage 4 ovarian cancer, endometrial cancer. Endometrial cancer, most patients, especially in early stage, are diagnosed and treated with a hysterectomy that's done robotically. So you can look this up on YouTube or Google it. This is the patient here. Of course, we don't cover your whole body in a blue sheet like that, but the patient's here. And what we do when we do robotic surgery is we dock these arms to the patient. I go to the patient's bedside and I place these arms in little incisions the width of my fingertip. And it's called robotic surgery, which is sort of a misnomer. It's more like remote control surgery, because what I do is then I go and I sit over here at this console, and with these little instruments down here, I drive these arms that are at the patient. And so there isn't a robot doing your surgery. It's just that I am controlling these arms via this console over here. And typically, most patients, like 90% of them, go home the same day. And very few patients are not a candidate for this type of surgery. But on occasion, there's a patient that just is not a candidate. After surgery, 70 to 80% are stage 1 at diagnosis. But although the majority of those stage 1 patients are cured, some of those stage 1 patients have risk features that require them to have radiation treatment. And very often we prescribe something called vaginal cuff radiation, which is called brachytherapy. And that's even in a stage 1 patient to reduce your chance of recurrence. Sometimes in highest risk patients, we have to do radiation. Of course, if you're a stage 3 or 4, you need chemotherapy, carbotaxol. You might get some radiation with that carbotaxol, but you definitely need carbotaxol as your most important critical point to your chemotherapy if you have a more advanced stage. Now, 2023 was a big year for endometrial cancer. There was like standing ovation, tears were being shed at our annual meeting. It was a big year for endometrial cancer. We saw in recurrent or advanced endometrial cancer patients, like if you had a stage 3 or 4 and you had one of these markers that I talked about in the earlier slide called deficient in MMR or dMMR, if you were treated with this immunotherapy called the dostarlimab, and there was another study that used something called pembrolizumab, if you were treated with one of these immunotherapy agents and you had this deficient in MMR subtype, your 2-year survival chance was 60.5% compared to 4% if you didn't get the immunotherapy. And this was the probability of remaining in response at 2 years. So this was a huge breakthrough for a certain type for 30% of our advanced or recurrent endometrial cancer patients. So really big deal. Again, ask your doctor if you have advanced endometrial cancer, ask your doctor about immunotherapies, because that was a big deal for 2023. Now, there's also a hereditary risk for endometrial cancer. It's not super common, but there's a syndrome called Lynch syndrome. And if you have a lot of colon cancers and uterine cancers or endometrial cancers in your family members, even can have ovarian cancers or cancers of the urogenital tract. If your family has a lot of those cancers, you might have this syndrome called Lynch syndrome in your family. So some other news for endometrial cancer is this issue called next generation sequencing, which I'm not going to talk about a lot here, but if you have an endometrial cancer or even a ovarian or a cervical cancer, ask your doctor about tumor testing if they've done something called tumor testing, which is also called next generation sequencing. Because if you've had, for example, HER2 testing on that report and you're positive, you might be eligible for some other treatments that I didn't talk about today. For example, one called Herceptin. Herceptin is usually a drug for breast cancer patients, but we're finding in gynecologic cancers that on occasion we have a patient that has a HER2 positive test and they could get benefit from treatment with Herceptin. We're also really using new therapies for recurrent endometrial cancer that we didn't use before. For example, a drug combination called Len-Pem, which is pembrolizumab with a pill called lenvatinib. That combination was better than standard chemotherapy. So we're using alternatives to standard chemotherapy in recurrent patients. And then really important that patients ask about and advocate for clinical trials in this disease site. Again, if you've tried carbotaxol, you've tried immunotherapy, really ask about clinical trials, because that's going to be kind of your best bet for finding something new, because traditional chemotherapy just unfortunately overall is not working that great for these endometrial cancer patients. And then I want to highlight there's this new maintenance therapy clinical trial that uses a pill called selinexor. So if you have endometrial cancer, advanced endometrial cancer, or recurrent endometrial cancer, or you have a family member or a friend that's getting treatment, ask about this clinical trial called selinexor. So selinexor maintenance therapy is potentially really exciting for a certain group of patients, and we do have trials currently open and enrolling for that drug. So last but not least, let's talk a little bit about cervical cancer. I think we have a couple minutes here. So this is a myth. Women in the United States no longer die from cervical cancer. So it didn't make it to those top 10 most deadly or most common, but women are still dying of cervical cancer in the United States. And it can be women like you and me, like anybody can potentially be at risk for that. So these are risk factors for cervical cancer. This is the cervix. This is when we look with a speculum in the vagina. Sometimes we'll see a tumor like this on the cervix and we biopsy that. But these are other risk factors. Almost most, but not all of our cervical cancers are due to HPV infection. But some other risk factors like increasing age, immunosuppression, lower socioeconomic status, tobacco use, infrequent or no prior cervical cancer screening or pap tests, those can all be risk factors for cervical cancer. And in fact, in the United States, about 5,000 women will die from cervical cancer a year, and there'll be about 14,000 new cases a year. It's the third most common gynecologic cancer, and the 12th most common cancer in general in women. But worldwide, it's the fourth most common cancer. And worldwide, for example, in 2012, that's an old statistic, there were about 500,000 cases, which probably is only increasing. So worldwide, it's very, very important. And it's one of the more common cancers worldwide. Cervical cancer, of all the gynecologic cancers, is the only one that we can prevent. And like I said earlier, it's the only one that we have a screening test for. So vaccination is critical. HPV vaccination is recommended starting at age 11 to 12. And this Gardasil 9 is a vaccine that includes these 9 different types of HPV. And it's 93 to 100% effective for eliminating, meaning preventing entirely, precancerous cervical cancer, precancerous cervical dysplasia or cervix cancer. So it's prophylactic, not therapeutic. It is really, really important that we educate. And we're now able to use it up to women age 45. And so really, really important to educate on this. Cervical cancer also has a screening test. What is it called? The pap smear. Now, more important than the pap smear potentially is that you get a pap smear with an HPV test. So if you or your family members or friends see your pap smear result and you don't see an HPV test on there, ask about it, because it's really standard to get HPV testing. Thankfully, if we pick up on these lesions that are precancerous or these HPV infections, it takes a while for that to develop into cancer, like 15 years sometimes. So if we're able to really find that before it happens, we can prevent the progression to cervical cancer. And that's why a pap test and an HPV test are really important. And sometimes we do a colposcopy if you have an abnormal pap smear to find these lesions, these precancerous lesions. But sometimes we don't just find a precancerous lesion, we actually find a cancer. But again, the goal of a pap smear, an HPV test, and colposcopy is to find these ahead of time before they develop into cancer. Cervical cancer patients have irregular bleeding, especially bleeding after intercourse. They might have irregular vaginal discharge, bad odor. If they have really advanced disease, they might have leg swelling, sciatica pain. They might have flank pain if the kidney's being blocked by this tumor. And most importantly, when we suspect a cancer, we have to do a biopsy. So really important that you're getting checked. Now, cervical cancer treatment is a spectrum of different approaches. If you're lucky enough that we find it early, you might just need a simple hysterectomy. or even just something called a cone biopsy, where we cut out a portion of the cervix to get the microscopic cervical cancer cells. But the larger the cancer gets, we might have to do something called a radical hysterectomy, which is removing a bigger portion of the cervix and the surrounding tissue. But unfortunately, if the cancer spread beyond the cervix into surrounding tissues, sometimes you're not a surgical candidate and you need radiation with chemo. And then last but not least, which is very unfortunate, is if the cancer's spread so much that it's in your liver or your lungs or your lymph nodes or your bone or your intestine or your bladder or your rectum, you're not a candidate sometimes for radiation even. You need full dose chemotherapy. And guess what chemotherapy that is? Carbotaxol. But we have some updates with this that I'll get into. So there's supposed to be, it didn't show up in my slide, but there's supposed to be a big circle with an X through it. We do not do robotic surgery for cervical cancer because we found in this study that women that got robotic surgery for cervical cancer actually had worse survival. So we don't offer robotic surgery for cervical cancer anymore unless studies down the road are going to prove to us otherwise. This is the uterus. This is the cervix with the cancer on it. In a radical hysterectomy, we get more than just the cervix. We have to go out laterally and get portions of the vagina and portions of the tissue that are beyond the cervix. So this is a longer, more involved, higher risk surgery than just a routine surgery. Than just a routine hysterectomy. Important to get that. I'm going to go through this kind of quickly, but if you are a stage 1B2 to stage 4A, what we call a locally advanced cervical cancer, you're not getting surgery necessarily, or most of the time you're getting a combination of radiation treatment that I don't give. That's the only thing I don't give. You have to go to a radiation doctor to get this, combined with chemotherapy. And that chemotherapy is a low dose chemotherapy called cisplatin that we give weekly while you're getting this external radiation treatment. And in this patient population, newsflash, January 2024, the FDA approved using pembrolizumab during chemoradiation for stage 3 to 4A cervical cancer. So now, if you're diagnosed with the stage 3 to 4A cervical cancer, FDA approved the use of pembrolizumab with your cisplatin and radiation therapy. That's big news, just a week or two ago. And then in advanced or recurrent cervical cancers, outcomes have really improved. When I was in training, I used to tell these women overall survival 6 months. 6 months. Then it went to 12 months. Then it went to 18 months. And now with the most recent study that you see down here, I'm able to tell women that it can be 3 years, that there's about a 40% reduction in the risk of progression or death in women that are using standard chemotherapy, carbotaxol, with that drug called bevacizumab and an immunotherapy called Keytruda or pembrolizumab. So really improving outcomes in these women, which I love to see. We also have a new drug for recurrent disease, which is a new class of drugs called an antibody drug conjugate. So you might be eligible for something called tisotumab vedotin, otherwise known as Tivdak. That's given now for recurrent disease where the patient already was treated with carbotaxol. And so let's continue this momentum. We're making progress in all 3 of these cancers, which is great. And, you know, I've been in practice for the last 13 years or so, and things are getting better, I can say. And the reason why things are better is that we have patients that are willing to go on clinical trial. And it's really not just for you to maybe do better, but for you to help advance the science and make our outcomes better and make the FDA approve new therapies for these cancers. I encourage patients and family members and friends to look on clinicaltrials.gov, or you can even go to uclahealth.org. There's this cancer clinical trial website that you can look at to see if you're eligible for a trial. Really, really important. Don't hesitate to ask. Don't hesitate to look this up. I will also tell you that many of these trials provide transportation vouchers if you live far away from the center that has the trial open. Some of them even provide housing vouchers, like stay vouchers. So really encourage you to look for these options, and then let's continue to educate. Social media, friends and family, community educators. If you're a patient that has one of these cancers, I get it, social media is not for everybody, but I think that's a great way for you to get the word out and educate about these treatments. And that's the end of the talk. We have like 8 minutes left, I think. So thank you so much for your attention. This is me, this is the website, this is where my practice is. Thank you for your attention. Happy to take any questions.